Hey guys, today we are talking about a head and neck examination. It tends to be kind of a long one because the eye can take up quite a bit of time, so we're going to get started and try to get through this fairly quickly. But first I wanted to talk about just some basic health maintenance that's related to this topic. So when we're talking about the head, the big health maintenance that comes with this is helmet use. So you need to make sure that you're educating your patients to wear helmets when they're riding bikes, when they're riding motorcycles. Outside of Hawaii, we used to always have to educate people to wear helmets when they're skiing and snowboarding and things like that. For infants, there's a couple concerns that as a clinician you should be educating your parents about. Shaken baby syndrome has gotten a lot of attention, and many hospitals have initiated new parent teaching while they're still in the hospital. So a lot of parents come out of the hospital knowing about shaken baby syndrome and knowing that they shouldn't shake their baby. But they don't know that about rotating the baby's head each night. So they need to rotate the position of the baby's head each night in order to reduce those plagiocephalies and the skeletal head deformations, deformities. So when you are seeing newborns, make sure that you're including that information in your newborn teaching. Okay, so the most common concern when we talk about headaches, or when we talk about the head exam, is headaches. So we're going to go through this a little bit. Serena Williams, 32-year-old tennis player, we all probably know who she is. She's had intense headaches, which cost her a tournament match over the weekend. So what is her chief complaint? It's headache, right? There's a whole bunch of differential diagnoses that can go with headache, and I've listed them here for you. Migraines, tension headaches, cluster headaches, sinus problems. It could be something like vision problems or allergies, any sort of illness that can cause a headache. It can be something terrible like subarachnoid hemorrhages or subdural hematomas. It can be a neoplasm, like a brain tumor. It could be a stroke. It could be temporal arteritis, or it could be something like menstrual related or something like that. So the differential is quite large. Finding out what your history will help you narrow down that differential. So timing, when is it acute? Is it chronic? Is it intermittent versus constant? So what's the duration of it? How long does it last when you get these headaches? What's the timing of the day, timing of the month? Is it insidious, meaning does it come on and kind of gradually get stronger, or is it just sudden onset? Where is it located on the head, frontal, facial, occipital? Behind the eyes? Is it band-like, so all the way around the head? Is it temporal? Is it one-sided, both-sided, or all over the place? What is the quality like? What is the severity? These questions will help you narrow down your differential diagnosis, as will your pertinent positives and negatives. You'll want to ask about fever and chills and weight loss. This could rule out meningitis or some other infectious process. You want to ask about skin, rashes that can indicate more the meningitis thing. HENT, trauma, photophobia, vision changes, eye pain, URI symptoms. These are leading towards the migraines and the sinus infections. Neck stiffness is a classic with meningitis. So if you ask the patient, do you have any stiffness in your neck? No? Okay. Do you have any nausea, vomiting? Is there an aura with your headaches? Do you know that they're going to occur? Do you see spots, or do you get this sense of, I know that this migraine is going to occur? That's called an aura. Any other neurologic symptoms like numbness, weakness, mentation changes. Do you take medications, including any herbals or as needed medications? And then the family and personal history is also pertinent. If you see someone with a progressive headache that's been getting worse and worse and worse and worse and worse over the course of hours, days, then that's a red flag finding. That means they need to get in, you need to see them, you need to probably work this up. If you see a patient with a sudden onset headache, like a thunderclap, what we call that, just a lightning strike, that just thunderous, all of a sudden, massive, terrible headache, that can indicate a bad problem, and they should come in and be seen, and you consider sending them, working them up or sending them to acute. That could be a subarachnoid hemorrhage or meningitis. Any headache in a patient that is new, that patient that's over the age of 50 that says, I've never had a headache before, and now they have headaches, that's red flag also. Also, headaches that worsen with position change, headaches that are associated with fever, night sweats, weight loss, neck stiffness, those, think meningitis. Any headache in a patient with cancer, pregnancy, or HIV always needs to be worked up. That's always a red flag for a more serious condition. And then any headache in a patient who has had recent head trauma or falls. Okay, so let's go back to our patient Serena, who lost her tennis match because she was so debilitated and couldn't function from her headache. So during your history, you find that her headaches occur monthly around her menstrual cycle. They're severe, 6 to 8 on a pain scale. They last 1 to 2 days. They're temporal and have occurred for the last 3 years. So is this a red flag? No, this is a chronic thing. It's happened for a long time. It's not any worse than it usually is. So it's not anything, the red flags aren't going up. She has associated nausea and menstrual cramping as well. She has no red flag findings, and the review system is otherwise negative. Exam is benign, so there's no neurologic deficits on exam. And you diagnose her with, what do you think? Probably just menstrual-related headaches. Yeah, tension headaches or so, but could be migraines too. But they seem to be menses related, right? Good. Okay, so when we get to the head, you want to inspect. You're inspecting the scalp, the skull, the face, the skin. You should also be palpating the face, the temporal artery, parotid gland. You can palpate the submandibular gland, the TMJ, and the sinuses. In kids, you'll want to palpate the fontanelles, and you'll want to palpate the suture lines on the heads of little kiddos. When we're talking about the scalp, you're looking for dandruff, for those ukus that we talked about last week. You're looking for lumps and scaliness. You can pick up things like seborrheic dermatitis or cirrhosis. You might see little creepy crawlers and ukus. This is a picture of a patient with psoriasis along that scalp line, which is fairly common. Not the most common. We think of psoriasis usually as affecting your flexor tendon or flexor surfaces of extremities, but it can also occur along the hairline here. You want to assess the skull for size, for contours, for any deformities. Look for these abnormalities, hydrocephaly, microcephaly, plagiocephalies, and evidence of traumatic brain injury. The plagiocephalies are those deformed heads from your kiddos' deformed heads that usually occur from a suture line that closes prematurely, or maybe the infant spent too much time on one side or preferred one side of their head and it wasn't rotated. If you're seeing this woman and you're asking, you probably wouldn't want to document that her head is normocephalic and atraumatic, because it's not. You can obviously see that there's been something that occurred there, some sort of craniotomy. So make sure that you are observing for those sort of areas. When you're looking at the face, you should look for symmetric asymmetry. Make sure that it is symmetric. Look for asymmetry. Involuntary movements. Look at their affect and their expression. Look for facial movements. You might pick up these common areas, like if there's facial asymmetry, that can indicate a Bell's palsy. Or even a stroke, or an old stroke, history of stroke. You might see moon face with Cushing's disease, that kind of round face. You might see a patient with a really flat affect. So people with Parkinson's or depression just have that really flatness to their face, like expressionless, like they have a mask on, what we call masked faces. You might see periorbital edema, common with thyroid dysfunctions, and potentially hirsutism, which could lead you to consider polycystic ovarian syndrome. This is a kid with, with a moon's face from Cushing. And this is a person with Bell's palsy. So he is smiling, trying to smile, but you can see only his right side is actually smiling. So he's got left-sided facial droop. You need to palpate. When we're palpating, palpate the temporal arteries. You should be looking for pain and pulses. You can palpate the parotid gland. These are generally going to be more special techniques. You wouldn't do this on, you might do this on a physical examination, just an annual physical exam, but you wouldn't want to do, you would generally save these for when the patient's complaining of something on their face. Submandibular gland, the TMJ, and sinuses. So you need to make sure that you're palpating those sinuses, usually in patients who complain of URIs, upper respiratory infection symptoms, or cold cough symptoms. Just a note about the pediatric head examination. You do want to assess the fontanelles. Remember that the anterior fontanelle closes about 12 to 18 months. The posterior fontanelle closes by 2 to 4 months. So many times, actually, but before you're seeing the infant for their 2-month visit, the posterior fontanelle may have already closed. Normally, the fontanelle should be slightly depressed in relation to that bony ridge around the skull. If it's bulging and the kid's crying, it's probably a normal finding. The kid's just crying, so make sure that you recheck when the kid is settled down, but it can indicate increased ICP. Check to see if the fontanelle is depressed, then that could indicate dehydration. Head circumference and fontanelles you want to check at every wellness visit for the kid, the 2-month, 4-month, 6-month, 9-month, 12-month, all of the normal pediatric milestones, you'll be assessing the fontanelles and the head circumference. On review, a normal head, you can say the skull is NCAT. That means normal cephalic atraumatic. That's a common abbreviation that you can use from now on. NC/AT. Usually there's a little slash there. Good. Hair, oh yeah, we talked about hair at the last lecture, so you can kind of bring that information in. For a pediatric exam, fontanelles are without depression or bulging. And then you can read the rest of that. The eye examination. The eye examination, there's a lot of components to the eyes, so you need to make sure that you kind of have these areas down. The related history or the red flag findings or any vision loss that's sudden onset, any new neurologic symptoms like diplopia, that's double vision, sorry, weakness, vertigo, and dysarthria. Especially if the vision loss is related to trauma, then that's a big red flag sign. So the patient that had, was playing baseball and took a baseball to the head, and now they can't see, that could be a retinal detachment or something. So any new onset pain, redness, or orbital signs, you'll want, you'll want to get that patient urgently evaluated. I've listed here your urgent differential, and then the next slide has your common differential. These are going to be less common, but if you suspect them, you need to get them evaluated right away. So acute open angle or acute angle closure glaucoma is that severe pain, usually dilated pupils, one-sided acute vision loss, and it is occasionally associated with nausea, vomiting. A retinal detachment is that visual field loss without the central loss. So a lot of times the field goes first. People might have flashers, floaters, and peripheral loss, and it sometimes is associated with those traumatic cases. Giant cell arteritis is not very common, but it is a sudden, severe, usually one-sided vision loss in older patients and older adults, associated with weight loss, headaches, and jaw claudication. The more common differential is going to be that slow progressive vision loss. So presbyopia is just that kind of age-related slow progressive vision loss. Glaucoma is the vision loss that typically starts with your peripheral vision. It's generally going to be older adults, and they'll have a family history of this. Your cataracts, again, they'll be older adults, usually even older than your glaucoma patients. They may have blurry or cloudy vision and defects in that red reflex, so they have that clouding of the red reflex. They may have diabetes. Then your diabetic retinopathy, which is still the leading cause of blindness out of all of these vision loss, out of all these vision problems. Diabetic retinopathy leads to that leaky blood vessels behind the eye and chronic progressive vision loss. So when you see a patient for vision loss, you need to ask them about past medical history that's pertinent to this topic, which includes diabetes, hypertension, glaucoma, and others. hypertension and diabetes are still a leading cause of blindness. So you need to make sure that you are assessing for those and making sure those patients are going to their eye specialist. Your review of systems questions related to vision loss is: have you had any problems with your eye, any vision changes, any foreign body feelings? For kids, you might ask, if you're trying to assess if they've had eye problems, you might ask if they have poor performance at school, if they're squinting or tilting their heads. I've had patients come in, or parents come in and bring their child and say, the teacher told me I should get his eyes checked because he's squinting and looking sideways at the board, or it used to be a chalkboard, now it's a whiteboard. Then it was a whiteboard, now it's probably a smart board of some sort. And then for your health maintenance, you need to ask people when their last eye examination was. For the examination of the eye, there's a lot of different aspects of this. First is just the inspection, the overall inspection, which we'll talk about all of these components. Then there's the visual acuity test, where you're testing the acuity of the eyes, usually with a Snellen or pocket card. There's extraocular movements. You can test the visual fields, and then you can do the fundoscopic examination. Inspection really starts with just looking at the eyes, the eyelids, the eyelashes, the lacrimal ducts, the puncta. You'll look at the palpebral conjunctiva, the sclera, the iris, and the pupils. You will pick up some of the common abnormalities like hordeolums, which are styes, so you should call them hordeolums from this point on. Blepharitis, that irritation along the eyelashes. You might pick up conjunctivitis, or injection in the conjunctiva. Subconjunctival hemorrhages, which are those bright red kind of flare hemorrhages. I think there's some pictures coming up. You might see foreign bodies, pterygiums and pinguecules, which are really common here in Hawaii because of the sun and the wind and the surf and all that. So pinguecules are benign yellow, kind of sometimes whitish deposits on the conjunctiva. They're more often on the nasal side, but they can be either. They're related to UV and wind exposure, so really common in patients that surf, that do a lot of water sports, or outside exposure where they're not wearing eye protection. There's some evidence that shows that pinguecules could be a precursor to a pterygium, which is generally a little bit worse, not benign. It can actually grow into and affect the pupil. So a pterygium is this triangular kind of thickening of the bulbar conjunctiva. It grows across the outer surface of the cornea. And this can affect vision when it grows into the pupil. So this is a pinguecule. You can see right here, that kind of area. And then this is that pterygium. This is actually a really bad pterygium, but this pterygium you can see is that triangular thickening. It's kind of growing into the pupil. So this person definitely has a lot of visual deficits because of this. Again, this is a very severe case. I've never seen one this bad. This patient just has conjunctivitis. You can see all this injection here into the eyes. And here we're showing you this hordeolum right here, this stye or hordeolum. This patient has a schizalian or a chazalian. I've heard it pronounced either way, but it's this large kind of lump below the eye. Sometimes patients will get them on the eyelid above as well, but they're not right on the eyelid margin like this stye, like this hordeolum is right there. So that's right along that eyelid margin, where the schizalian is kind of deeper in the tissue right here. Here's a picture of that subconjunctival hemorrhage. Very painless, but it looks bad sometimes. It's bright red. It's sharply demarcated. It might turn, or definitely will usually turn yellow as it starts to heal. And sometimes, so if you see it in its varying stages of healing, it might look like jaundice or something else. But it's usually painless, just a blood vessel that's sort of popped open. Sometimes I see these a lot after patients have had a lot of coughing or a lot of vomiting and things like that. This is an Arcus Sinalis. This is a white or gray, sometimes bluish opaque ring around the corneal margin. So that ring is common sometimes at birth. You might see this at birth, but then it'll fade away. But it's common also again in the elderly. Earlier in life, it sometimes is associated with hypercholesterolemia if you see it in a patient that doesn't have that's not old or newborns. Think about their cholesterol levels. Here's just a brief review of your normal and abnormal findings related to inspection. So remember calor, rubor, dolor is calor is heat, rubor is redness, dolor is pain. Good. Okay, so the visual examination, the Snellen chart and the Rosenbaum pocket charts are two of the really commonly used tools. The Snellen chart is that big E chart that is usually 20 feet away. And so they shouldn't be new to you. So take a look at this. All these examination techniques are in the videos as well that I've posted for you. Visual fields by confrontation. Here you're trying to assess the peripheral vision of the patient, and you're making sure that they have vision in all fields. So remember that your eyes should be, you have all these different cardinal views of gaze. So you have all these different views, and you want to make sure that the patient can see in all of their different visual fields. So you're asking the patient to look into your eyes. You're putting your hands 2 feet apart, lateral to the patient, and you are bringing your hands towards their peripheral vision. And you're doing this high and low, and then switching and doing it again. So make sure that you're watching the video. It shows this, and it's pretty easy. So the patient should see both fingers at the same time, and they should have vision in all fields. If you catch an abnormality in here, then again, this is just a screening tool, so you want to refer them on to an ophthalmologist or an optometrist for more formal visual testing. The pupil examination, you'll want to take a look at the pupil size, shape, symmetry. We usually measure pupils by 1 to 7 millimeters. Pupils are usually brisk. They are reactive to light, and they're usually symmetric. It's not always the case. We do see anisocoria is a condition in which patients have pupillary inequality. So the pupils are different sizes, but usually that's going to be present for a long time. The patient will say, oh yeah, I've had that in the past. I've always been that way. And it could be found in upwards of 20% of the people. If you find anisocoria in a patient that doesn't have a history of that, then it could indicate one of these problems. And I have seen a Horner syndrome before. This is where there's some ptosis of the eyelid, and in this lady's case that I saw, it was probably like 6 or 7 years ago, it was associated with a dissecting vessel in her neck, one of her carotid dissection, which is really, really severe. So we caught it early, and she went in and had intervention, and it was fine, but kind of scary. It could also be associated with oculomotor nerve paralysis. There's also ptosis with that. The pupil is generally dilated and fixed. A tonic pupil, this pupil is generally going to be kind of large, and usually it's one-sided, which all these generally are one-sided. It's not real brisk to light, so there's going to be reduced kind of sluggishness to light reactivity. Sometimes even there's no light reactivity. But if you see anisocoria in a patient that doesn't have a history of it, make sure you're getting them evaluated by an eye specialist. Okay, so when you are looking for pupillary reaction to light, you ask the patient to look into the distance, you shine a bright light into each pupil. The direct reaction is that the pupil that you're shining the light into should constrict. The consensual reaction is that the pupil that you're shining the light into, the other one, where the light isn't shined into, that one should also constrict. That's called a consensual reaction, because the eyes work as a pair. So if one of them constricts, the other one should constrict as well. So if you shine a light in the right one constricts, that's a direct response or direct reaction. You shine a light in the right one and the left one also constricts, that's a consensual reaction. So you do that to both eyes. Right? So you look for the direct and consensual in each eye. So you should be shining the light in the patient's right eye twice and their left eye twice to check for both direct and consensual reactions. You can check for a near reaction. So you have the patient look at an object close to their eyes, about 10 centimeters, and then look at something far away in the distance, and then look back at the near object and look at something far away in the distance. The pupil should constrict when they're looking at something close up. You can also test extraocular muscles. There are 4 tests that can be used to check the muscles. These are the corneal reflections, the cover-uncover. The most common one is going to be your extraocular movements, and then your convergence test. Okay. So the corneal reactions or corneal reflections, here you're really just shining a light into the patient's eyes and having the patient look in that general direction. And you're inspecting the reflections on the cornea. They should be visible in the reflection of that light should be visible, slightly nasal to the center of the pupils. If it's asymmetrical, that can indicate a dysconjunctive gaze, meaning that one eye is, the muscle of one eye is a little bit weak, so maybe you're not picking up the light reaction in the right place in one eye. That could be a strabismus or what we call lazy eyes. The cover-uncover test. This is a test that is useful for looking at strabismus, which is, again, that lazy eye. So this isn't generally done all the time unless the light reflection is abnormal. So if you think you see a little bit of an abnormality in the light reflection, the corneal reflections, then go ahead and do the cover-uncover test. So you have the patient stare at an object and you cover one eye, and then you uncover the eye, and that eye may have kind of deviated off when you cover it. So covering the eye, remember the eyes work in pairs. So if you cover one eye, it should still be looking at whatever your other eye is looking at. So when you uncover it, if it's off wandering and doing its own thing, then there's a muscle problem or a gaze problem. Potentially a nerve, optic nerve problem. Okay, so your extraocular muscle movement, so your EOMs, this is where, we call this the big flying H, your 6 cardinal views of gaze. You ask the patient to follow your finger and you make the large H in the air. You're testing their 6 cardinal views, the lateral superior, the extreme lateral, the lateral posterior, so over and down on both sides. And you're looking that the gaze should be smooth, that the eyes are working together. There's a normal conjugate movement of the eye in each direction, and there's no deviation from normal. You might pick up nystagmus, which are those fine kind of rhythmic oscillations in the outer, when they're in the extreme lateral aspects of their gaze. A few beats on that lateral extreme is normal, but if it's a continuous nystagmus, that's not normal. You can look for convergence after you've done that big flying H and tested the 6 cardinal views of gaze. You can bring your finger back to middle and then bring your finger in towards the bridge of the patient's nose and have them follow their finger into their nose until their eyes cross and they can't see it any longer. So that usually occurs around 5 to 8 centimeters. Okay, so the last part of the eye examination, and the part that students often are concerned about the most, sorry, let me get rid of this, is the fundoscopic examination. So this is in your video on your learning site as well on Blackboard, so make sure you're looking at these videos because they might make more sense when you're actually demonstrating them other than just telling you about them. So the fundoscopic examination starts with the fundoscope or the ophthalmoscope. So you want to look at the equipment, kind of figure out how to hold it and where to put things. Your finger should be on that diopter, the diopter dial, which you can see that the clinician in this picture's finger is on the right side. So the right and the left are the same. You can move it from either side, so it's not like you have to be able to push both sides. So just one side is fine. And then look at the aperture. That's that part that you look through, and then the lens disc will show you kind of what the numbers are where you are at. The lens disc, as it rotates, there's different size light beams. So there's the slit beam, there's the green light, there's the grid, depending on your needs. But generally, just set it to the large round light. You're going to be able to see best. So you remove your glasses and the patient's glasses. You shine the light on the back of your hand to make sure that the bright round light is on, and it's not the slit one, it's not the green one. Set the diopter at 0, and then hold the ophthalmoscope in the same hand as the eye that you're going to examine. So if you're examining the patient's right eye, the ophthalmoscope should be in your right hand, and you should be looking through it in your right eye. That way you're going your right eye to the patient's right eye. And that way you're not going to bump noses and Eskimo kiss them, which makes everything a little bit awkward. So make sure you're standing to the side of them and going right eye to right eye, and then left eye to left eye. So 15 inches, 15 degrees from the patient. Place your ophthalmoscope against your bony orbit. So your hand, usually I have it in my hand and then put my hand against my bony orbit. And then have the patient look over your shoulder and generally up towards the wall, towards where the ceiling meets the wall, and have them look kind of upwards. And then you're shining the light beam. Look for the red reflex. Everybody's really good at finding the red reflex. So once you found the red reflex, then follow that red reflex in and try to see the blood vessels behind the eye. So the most common reason that people can't see anything is because they're standing too far away. You do need to get really close to patients when you're checking the when you're checking their fundus and looking behind their eye. But try not to run into the patients. Definitely don't. You can, once you can see a vessel, that's when you can start changing the diopter dial to make it come into view. So this is especially important if you wear glasses normally, or the patient wears glasses normally, and you have taken those off. You may have to change those. Otherwise, 0 is probably a fine setting, but you do need to account for errors in refractory for yourself and the patient by changing that and focusing those areas into bringing those areas into focus. So once you're able to see, you can follow blood vessels around. You can look for the optic disc, and I'm going to show you real quick why this is almost impossible sometimes, especially for new clinicians and people who don't do this all the time. So when we are looking for these optic disc and optic cups, which, the optic disc, we tell you it should be sharp and clear. It should be white or somewhat pigmented. Crescents can be normal, and it should be less than half the size of the disc. And the disc then should be, the optic disc should be this yellow, orange, or creamy pink structure. So we have the disc, which is that yellowish orange or creamy bigger disc, and then the cup, which is smaller, and it sits in the middle of the disc, or the cup sits in the center of the disc. And the cup shouldn't be more than half the size of the disc. But it's almost impossible to actually see these things, and I'm going to show you why. Okay, so seeing into the back of the eye, we tell people it's like looking through the keyhole of a door and trying to see the room. So you're trying to see the room just through this tiny little keyhole in the door, the hole where you would put the keys to get into the door, so like the lock, the little key lock thing. So you're not looking through the big picture window where you can see the entire room. You're looking at this you're looking through this tiny little hole and trying to see the whole room. So it tends to look like. So when you're looking at the back of the eye, you are not looking through a big picture window into a room. It's not like you're able to see the entire back of the eye all at once, like a photograph. Instead, you have to look at it small sections at a time. So we say that it's similar to looking at a room through a keyhole, through the little keyhole in the door. So you're only seeing a little bit. And to illustrate, a tube. So let's play this. So this is what you're seeing. You're seeing that little circle. Oh, so right there, did you see that? That's a blood vessel, and there's the optic disc, and there's more blood vessels. So that's what you're seeing here. You're not seeing the entire room. Okay, let's go back here. Okay, so it's difficult, it's challenging, and you need to become really good at this before it even makes a little bit of sense. But hopefully by the end of lab, you're able to see blood vessels and maybe follow those blood vessels around. So you're looking for, you might be able to see the optic disc and optic cup. That's great. But hopefully you can at least see blood vessels and look around the back of the eye, the retina, and see if there's any other changes. Things like AV nicking, which is where the veins and the arteries, when they meet and they cross, there's a little bit of, the vein stops on either side of the artery, and that can indicate some hypertensive changes in the eye. You might also see some other changes in the eye, some of the diabetic changes. You might see some of the flame hemorrhages, and we'll go through some of those pictures. Other common abnormalities like cotton wool patches and some of the other harder exudates. So here's a normal picture. So this, if you could see the whole picture, this is what you would be looking at right here or right here. Now this is the whole picture. But what you're seeing is this section at a time, and you're moving it around to try to see all these little sections at a time. Okay, so it's pretty difficult. So you may pick up, hopefully, some cotton wool patches and some hard exudates. Those are what we call exudates. Those tend to be white, and the patches tend to be fluffier, and the hard exudates tend to be little white, discrete areas, and we'll show pictures of that. Hemorrhages are often seen in hypertension, diabetes. These are red streaks. Cupping is when the optic cup is larger in size than it should be, so greater than 50% of the optic disc, but also sort of looks like it has, it's kind of cupping forward towards you. It looks more three-dimensional, and that is associated with increased ICP. So on this slide, you can see common changes with hypertensive retinopathy. So you can see the hard exudates. You can see some of those soft cotton wool patches, these cotton wool spots. These are kind of fluffier. Let me pull this up. You can see that kind of fluffier spots there. These are the cotton wool patches. Whereas these tiny little discrete ones are the hard exudates. These are the flare hemorrhages, the kind of red flare hemorrhages. Good. Okay, and this is diabetic retinopathy. You can see that there's quite a bit of color changes, right? So you can see that the whole thing is kind of a darker pink color. And that's because the excessive blood sugar causes those small blood vessels to become really leaky, and this causes, that color. When the blood vessels leak, it kind of creates that kind of pinkish, more red color. So make sure your diabetic patients are well treated and that they are going to their clinicians, their eye clinicians. You can take a look here at, this is a picture of glaucoma. This is what I'm talking about when the optic cup is more than half the size of the disc. So you can see the disc there, you can see the cup is more than half the size. Papilledema is there's an acute form and then a chronic form. We all worry about the acute form because of the optic disc swelling and the increased ICP. Patients may be asymptomatic, don't have any symptoms, or they might have headaches and vision loss and can progress to complete vision loss. So make sure that you're getting these evaluated. Okay, so when will you do some of these examinations? So The adult the wellness exam, the comprehensive visit, you'll probably do, probably check PERLA, pupils equal, round, reactive to light. The extraocular movements should be intact. You should check the visual fields grossly to make sure the gross visual fields are intact. For pediatrics, you should check their vision test. You should definitely check PERLA and symmetric light reflex, maybe the cover, uncover, depending on their age and their engagement. If the patient has an eye problem, you should probably do a lot more of these. If they're complaining of blurred vision or trouble seeing, then you want to kind of do some more of these and then send them on to an eye specialist. If your patient has diabetes, hypertension, you want to take a look in the back of their eye as well. Even if they're seeing a specialist for it, then you still probably want to at least take a look. And always document when they saw their last eye doctor visit. Okay, so we're moving on to the ear. So this picture, I like this picture because it shows the external auditory canal there. That's that green part going in towards the ear, and it stops there at the tympanic membrane. So that darker green area is the tympanic membrane. Past the tympanic membrane is the middle ear, and that in the red it shows you the eustachian tube that goes down, and then how the eustachian tube kind of comes up. So it's just a nice little depiction of this, and you can see the malleus and the incus bones through the tympanic membrane sometimes. So try to remember this little structure so that you can take a look at it again. Common concerns with the ear are things like hearing problems, vertigo, pain, discharge, things like that. Little kids might have tugging at their ears, maybe delayed onset of speech, inattention or uncoordination. A lot of times with ear infections, kids will just, it's a sudden uncoordination. Like, the 3-year-old that, they've been walking for a couple years now, and they usually walk fine, and all of a sudden they become off balance, and they're running into everything, and the mom brings them in, and they're saying their ear hurts, and they have a big nasty ear infection or something. So your differential diagnosis for ear pain is generally going to be acute otitis media, otitis externa, maybe serous otitis media, eustachian tube dysfunction. Remember, the eustachian tubes kind of go up to the back of the ear. So if you have eustachian tube dysfunction or inability to regulate the pressure in the middle ear, then it can push on the tympanic membrane and cause some discomfort and some pain. When you're examining the ear, you should start at the auricle. That's palpate that external ear part. So the auricle, looking for lesions, looking for rashes, lumps, deformities. Sometimes you'll see these big keloids from patients that had piercings, and that piercing has been sort of scarred over, and the scar tissue has gone a little bit crazy and keloided. You can do what's called a tug test, where you're applying gentle traction or tugging on the auricle, and then palpating the tragus, that middle part of the ear. Pain can be associated with external ear infections, what we call swimmer's ear, or sometimes even otitis media, or the inner ear infections. Other tests that you can do here, like the otoscopic exam, the Weber's test, the whisper test, the Rin test, and then some formal auditory testing. Okay, so some points about the otoscope. Make sure that you're using the largest speculum on the otoscope that the canal can safely accommodate. You don't want to scrape the canal and become problematic, but make sure you're using the largest spectrum possible so you can get the best visualization. Position the client so that you can see well. Remember, you do this all day long. The patient can be uncomfortable for a couple seconds, but if you're constantly cranking your head and your neck and hunching down to see ears, then and you're doing that all day, then you're going to become uncomfortable quickly. It helps to straighten the auditory canal, or try to straighten the auditory canal. So in adults, pull the auricle up and back, and in children, pull the auricle down and back in order to straighten that canal out. When you're looking through the external auditory canal, you should look at cerumen, look for any redness, drainage, foreign bodies, or lesions. As you're traveling down the canal, look at the tympanic membrane and see what color it is. Look at the different aspects of it, the pars tensa and the pars flaccida, which is the different aspects of the tympanic membrane that I think there's a picture of here. The cone of light is just a light reflection. So the cone of light is just the reflection of your light. So in the right ear it tends to be at 5 o'clock, in the left ear it's at 7 o'clock. So here's a picture of the tympanic membrane. The pars flaccida is this area up here. So is this a right ear or a left ear, would you say? Where's the cone of light, the light reflection? You know, they drew it here as a white little circle, but it really will just be the reflection of your light. So it's at 5 o'clock, so this must be right ear, right? Get that? Okay. Okay, so here's a more normal look at it. That other one was kind of a drawing or depiction of the tympanic membrane. So here's the tympanic membrane, a real tympanic membrane, and this is the normal tympanic membrane. So here's that pars flaccida, here's the pars tensa, here is that cone of light. You can see that kind of white light reflection. So again, this is the right ear. And then you can sometimes see the bones behind. So you can see the handle of the malleus there. You can see the incus back there. Good. One thing that's not, I don't know if the scopes the otoscopes at school will have the insufflation, but a lot of them will have the insufflators, so those little puffs of air. So there'll be a little bulb that you can squeeze and apply a puff of air that makes sure that the tympanic membrane is mobile. So the tympanic membrane should be able to be moved. If it's not, then that's what can cause some discomfort. I'm not going to get into the physiology of hearing. I just wanted to let you guys know that there's two major phases of hearing. There's the conductive phase and then the sensorineural phase. So the conductive phase has to do with the vibrations of the sound that pass through the air into the external canal and then are transmitted through the eardrum to the middle ear of the cochlea, which is that middle part. So if there's a problem in this conductive phase, then this is called a conductive hearing loss. So this is common with cerumen impaction. You know, there's a lot of earwax that builds up into the external auditory canal, so it doesn't get the vibrations of sound. So the vibrations are a little bit changed because the ear canal is altered. So the vibrations are then altered. Whereas with sensorineural phase, this is where the cochlea gets that information and then codes it and sends the impulses to the brain through that cochlear nerve. So this is, so if there's a problem here from the cochlea to the brain, then this is a sensorineural hearing loss. And this is going to be those patients with viral infections. Sometimes you can damage the nerve from too loud of sound and things like that. So this makes sense when we're talking about the Weber and Rin test. So you have to sort of understand these phases of hearing and the physiology of hearing when we're trying to apply that to the Weber and Rin. The whisper test, you can test, I generally don't do this. I just, if the patient can hear me and understand me while I'm talking to them, then I assume that they can hear. So I don't necessarily need to test with the whisper test. But if a patient is saying that they're having trouble hearing, then you might want to do this to see which side they're having more trouble hearing out of. So you cover the client's ear closest to you, you press on the tragus, or you can have the patient do this, and then they need to close their eyes, and or you can just stand behind them, and then whisper softly a combination of 3 letters or 3 numbers, or a 3-word syllable, or 2 or 3 word syllables. So you can say basketball or apple, and have the patient repeat that to you. The Weber test, this is a test for lateralization of hearing. So if the patient has normal hearing, they should be able to hear the tuning fork when it's placed on the forehead. They should be able to hear that in both ears the same. So if the patient's hearing is normal, they're hearing it in both ears the same. If they have trouble hearing in their right ear, they're saying, oh, I can't hear it in my right ear. So you pring or prong or ding or dong or whatever you do to the tuning fork to make it do its vibration. You place that on the top of the client's head. If they can't hear in their right ear, so the ear that's causing problems that they can't hear in that, then it could be unilateral sensorineural hearing loss. So, conductive hearing loss. So that's the strange thing, is that with conductive hearing loss, you hear it better in the ear that they can't hear in. So they'll say, I can't hear in my right ear. But when you do this test, they're like, oh, I hear it in my right ear. That's strange. And that's a pretty simple thing to think about, because if there's something blocking the external auditory canal, if there's some material in there, remember that sound travels better through a material than through nothing. So that's why sound barriers usually have a gap where there's nothing there. A space, a pocket of air where there's nothing there. That's how they achieve sound barriers. And that's also why when you think of that telephone game where you have the two, you have the two tin cans and the wire or the string in between the two cans, you can hear through that because sound travels, the vibrations of sound travel through the string, and you're able to hear better. So the patient with the impacted cerumen, or the ear, the earwax impaction, can actually hear better these vibrations into that affected ear. So even though they can't hear better, they can hear this lateralization, this tuning fork better. If they have problems in their right ear, but the sound, they hear the sound of the tuning fork in their left ear, then that means that the right ear has sensorineural hearing loss. That's the right ear that the patient has problems hearing out of. Does that make sense? So we kind of think through that, and we'll practice that in class, but also watch your videos because we kind of go through those examples. You can also do the Rin test. This is a test to look at air conduction and bone conduction and the ratios of those. So you put the tuning fork, after you pring, prong, ding, dong, the tuning fork, you put it behind the client's mastoid bone, right behind their ear, and you ask the patient to tell you when the sound stops, and then you quickly move that tuning fork to the other side, to the opening of their of the ear, and they should still be able to hear the sound. So even though they quit hearing it through the vibration of the mastoid bone, when they move it in front of the ear, they should still be able to hear. So our normal finding is that air conduction is greater than bone conduction, so they're still able to hear it. With conductive hearing loss, it tends to be equal, or bone conduction might be greater than air conduction. So they can't really hear it when you bring it to the front. With sensorineural hearing loss, it's a normal finding, so air conduction is greater than bone conduction. Okay, so there's a couple things that affect the ear that you should be familiar with. This isn't a diagnosis course, but you need to be somewhat familiar with some of these, and you'll learn more about these in other courses. But otitis media, this is inflammation or infection of that middle ear behind the tympanic membrane. And usually this is caused by an infection. Sometimes it's caused by just fluid, and we call that otitis or serous otitis media. Otitis externa is inflammation and infection in the outer ear, that external auditory canal. And sometimes we call this swimmer's ear for patients that swim a lot and they get that kind of fluid buildup and it doesn't dry out and they get that infection kind of there. If you had a ruptured eardrum, and there's a picture of a perforated eardrum, there's a hole in the tympanic membrane which allows the membrane to equalize so there's no more pressure buildup. So often this occurs after a period of a lot of pressure. Sometimes it can occur from a really loud noise, and sometimes from foreign bodies and things like that. So here's a picture of otitis media. You can see the bony landmarks are gone. You can still see the light reflex here, so you can tell that this is the right ear because it's on the 5 o'clock, right? But the bony landmarks are gone, and this pars flaccida, this pars tensa over here, it looks swollen, kind of looks like a conch shell. And this might be a little bit of purulent, kind of serous material in the back of it too. So it looks swollen, kind of looks like that, like a shell of some sort, and it's bulging out towards you. So we would call this, a bulging tympanic membrane. It's erythematous and bulging. Whereas this is a perforated tympanic membrane. So you can see the pars tensa. Here's the umbo and the malleus. And right here is this large kind of tear in the membrane. All right, so we're going to move on to the nose and the paranasal sinuses. This is a pretty easy one because the only things here are going to be your sinuses and then your bridge, tip, ala, and vestibule, which are the external structures of the nose, and then the internal structures, which are the mucosa, the septum, and the turbinates. So here's a picture of where the frontal and maxillary sinuses are, so you can press on those areas when you're doing your examinations. Here is an internal cross-sectional picture of, so you can see where the turbinates are. So here's your inferior turbinate, here's your middle turbinate, and here's your superior turbinate. You're not able to see the superior turbinate, when you're looking up the nose with your scopes. You're only going to be able to see the inferior and sometimes part of the middle turbinate. Your common differential diagnosis for, or your common chief complaints in this section are going to be trauma, nasal fractures, nosebleeds, which we call epistaxis, allergies, URIs, and sinusitis. Sinusitis is probably the most common reason, and URIs and allergies. So all of it's really common. For rhinitis or runny nose, your differential is allergic rhinitis, vasomotor, or non-allergic rhinitis. Medicamentosa, those are those patients that have taken Afrin or some other medication so commonly that they've caused their nose to have sort of this chronic congestion and rhinitis. Sinusitis, polyposis, and deviated septums. Sorry, misspelling there. When you're looking at the nose, you should start, like all things, start with inspection. So you're inspecting the external structures, looking for symmetry, tenderness, piercing, looking for lesions. In this section, you can see the nasal crease sometimes, which is that crease along the bridge of the nose, which is common in patients with allergies and chronic rhinitis because they're, sniffing and pushing up on their nose often. When you're looking at the inside of the nose, at the mucosa, you're looking for color, looking at the swelling, for any swelling and exudates. If there is exudates or if there is any discharge, you want to know if it's clear, mucopurulent or purulent, what color it is. You should also be looking at the turbinates. Look for the inferior and medial. Again, you can't see the superior turbinate. And then look for any deviations in the septum. You may be able to see polyps hanging from the turbinates or from the middle meatus that they look like somewhat pale. They tend to be paler than the mucosa. And they usually come from that middle meatus. The mucosa of the nose is generally brighter, so a little bit more red than the oral mucosa, so that's a normal color. If you notice that the turbinates are kind of boggy and they're kind of a bluish or a pale color, then that can indicate some chronic allergies. So consider that when you're a patient with rhinitis that you're looking at and you're taking a look up into the nose and you're seeing that they have that kind of boggy color. It could be a chronic allergy. Your sinuses, you'll palpate the sinuses, pressure on the frontal and the maxillary. There's also ethmoid sinuses, but those are very small and not quite as likely to become a problem. Those are on the sides, each side of the nose, of the bridge of the nose. So generally, your larger sinuses, the frontal and the maxillary, are going to be more problematic. Okay, and then I think we're moving on to, the throat. So the mouth and throat. Here, the health maintenance, make sure you're talking to patients about patient education and health maintenance, including dental exams, brushing their teeth, making sure that they're using these things, and cessation of smoking, chewing. Some patients here, some clients use betel quid and betel nut and ask them to give them some education about the risks of those, especially as pertains to their dental and oral health. Inspection, again, always start with inspection. Inspecting the lips, looking for color, moisture, cracks, lesions. You can see some of these common abnormalities. Cheilitis, which is the fissures of the angles of the mouth. Herpes Simplex, which are these painful vesicles and crusting. Angioedema is that non-pitting, tense swelling of the dermis and subcutaneous tissue that hopefully you'll never see in primary care because hopefully the patient has gone to the emergency department. But if you do see it, send them to acute. Give them some Benadryl or something and send them acute. You will take a look at their dentition, looking at their gingiva and their teeth structure. Look for broken teeth, inflammation, dentures, bleeding gums, things like that. This is a picture of herpes simplex. You can see that painful vesicular eruption here. This case is just one single. A lot of times it is just one single lesion. Sometimes it can be a lot more problematic, though. There can be a number of lesions here. These are usually recurrent. So usually, there's always a first-time case that you're seeing something, but many times patients will come in saying, "Oh, I get this all the time. I've had this before. Can I just get treatment for it?" Here's the angular cheilitis. This is inflammatory. It tends to happen a lot of times when you go from hot and cold, hot and cold, hot and cold. So a lot of times when you get those sort of chapped lips from colder climates, when you're going in and out of the cold, it tends to be in the fissure of the mouth. It can also be related to some nutritional deficiencies and some eczematic type atopic dermatitis. Sometimes, rarely, can be a candidal issue. You'll want to look at the tongue as well. The tongue can show a lot about people's health. There's a lot of variations to normal for the tongue. A geographic tongue is very it's map-like pattern on the tongue. You can also see a hairy tongue, which is benign, but it looks nasty. It looks like there's this brown or black, sometimes yellow, growth on the tongue. You may see candidiasis, which is not normal. It's white coating on the tongue. Leukoplakia, which sometimes looks like candidiasis, but when you try to scrape it off, it won't come off, and this can be potentially cancerous, so you want to take a look at those. So this is a picture of hairy tongue. Sometimes this can be associated with antibiotic use, and sometimes it's just a chronic variant of normal, so take a look for that. You'll also look for aphthous ulcers. These are those little, usually circular or annular, shallow ulcers on the gums. They can be really, really painful, and patients will say, it hurts to eat, it hurts to bump my lip. They're on the mucosal around your lips often, sometimes associated with trauma, like you're biting on a pen and it kind of moves and scrapes your lips. Sometimes it's associated with nutritional issues, celiac disease, things like that. So, and leukoplakia we already talked about. You'll want to take a look inside the mouth at the throat and look at the tonsils and the pillars, noting any size, color, exudates of the tonsils. If the tonsils are really large, then that can indicate a tonsillitis, which could be bacterial, like a strep, or it could be a viral process as well. If there's one side, one tonsil is really, really large and protruding past midline, then that could indicate a peritonsillar abscess, which is a retropharyngeal abscess. It looks just like tonsillitis, except for it's generally it's much more severe, and it's one side versus the other. So high fevers. People tend to have difficulty opening their mouth eventually. They might have drooling and trouble controlling their secretions. So make sure you're looking for those. I've seen that probably 6 or 7 times over the course of the last 10 years or so. This picture is just showing you, illustrating the different components that you're looking for. So this obviously is the uvula. You have your tonsils right there and right there. You have your pillar here. This is your anterior pillar. So the pillars are just sort of the house of where the tonsil sits in between there. So back there, you can see this line is pointing back there. That's the posterior pillar. So the posterior pillar, the anterior pillar, and then the tonsils sit right in between. If your tonsils are surgically absent, then they've taken sort of this spoon-like thing and kind of scoop those tonsils out of there. So they kind of scoop them right out in between the two pillars. So you won't see the tonsils there. And here is a picture of my husband's throat when he was sick one time. And you can see that the tonsillar crypts here, these crypts are filled with like an exudate. He had quite a bit of cobblestoning, these kind of bumps on the back of his throat that lead down his throat from postnasal drainage and kind of that sinus drainage. Okay, so the uvula, it's normally midline. It might be surgically absent. You can have the patient say, watch the soft palate move. That's cranial nerve 10. We'll talk about cranial nerves when we talk about the neurologic examination. You might see torus palatinus, which is this benign kind of bony growth on the hard palate of the superior, on the roof of the mouth. It's a normal benign growth, pretty uncommon, but I have a couple patients with it right now in our homes. Okay, just a little bit about the neck. So the neck is fairly easy because we're going to talk about the carotid and the jugular pulses when we talk about the cardiac exam. So here we're just going to talk about the thyroid, lymph nodes, and the trachea. So you always, again, start with inspection and palpation. So inspection, the neck should be symmetrical. It shouldn't, the head shouldn't be deviating to one side. If you see a torticollis where the patient prefers one side over the other, then that can shorten the muscles on the other side of the neck, actually become a problem, become chronic pain and things like that. So you'll inspect and palpate the thyroid, the trachea, and the lymph nodes. Here's the different lymph nodes I want you guys to be familiar with. There's, hundreds and hundreds of lymph nodes throughout the body. But these are the ones at the neck that I want you to know. So we have the preauricular, the postauricular, you have your tonsillar, you have your submandibular, your submental right underneath the chin. Then you have your superficial cervical and your posterior cervical behind the sternocleidomastoid muscle, your occipital, which are kind of behind the ear on the occiput of your head, and then your supraclavicular. You also have infraclavicular that you might as well feel for while you're here as well. Whoops. So here's that list again in case you want to see it, and these are on your videos as well. Lymph nodes generally are small, they're soft, they're mobile, they're non-tender. If they're problematic, then they get large, firm, they may be painful. It's really the non-painful enlarged lymph node that you need to be concerned about, and make sure that you're checking back up. Tell the patient to watch it, come back in a month if it's still there, things like that. They might become erythematous, infection, and usually the two big differentials here are infection, some sort of infection, or possible malignancy. So you want to look into those two aspects. When we're talking about the thyroid, you want to look at the thyroid, inspect the thyroid, and look for goiters. And large goiters can easily be seen, and I'll tell you some stories when we talk about this in class, but of some of the goiters and thyroid abnormalities that you've seen throughout the years. But you palpate, you can palpate anteriorly, or you can use a posterior approach. Have the patient swallow so that as they swallow, the thyroid gland moves up. And so if you're palpating and you're having them swallow, then you're really bringing that thyroid up past your fingers, so it's easier to feel. Here's the picture. Here's a picture illustrating kind of where the thyroid is. So here's the sternocleidomastoid muscles, and then here is the thyroid gland here, the thyroid cartilage. All right, so we don't see a lot of goiters anymore because we don't have, the iodine deficiency problems in most countries, but in some third world countries you might still see this. So yeah, we've in the United States they iodize salt, and everybody uses salt in almost everything, so we don't really have the iodine deficiency issues. But goiters are just enlargements of the thyroid gland. It doesn't actually mean that the thyroid is overproducing or underproducing. It could be either. So you could have a hypothyroidism or a hyperthyroid state and still have a goiter. But you'll want to take a look at these. You want to take a look at the thyroid. Sometimes you can just see large thyroid swelling or thyroid tumors, but be aware of the subtle changes in the neck. You can use some tangential lighting and some good lighting source, but between your inspection and your palpation, you should be able to pick this up.